Welcome to this video on right heart catheterization and pulmonary hypertension. We will provide a clinical guide covering techniques, hemodynamic assessment, and the evaluation of pulmonary hypertension, ranging from diagnostic algorithms to advanced testing. This video is divided into 4 main sections: an introduction and history of right heart catheterization, procedural techniques and measurements, an overview of risks and limitations, and a final section on advanced testing methods. Right heart catheterization has a rich history dating back to 1929. Significant advancements in the 1940s and the 1967 refinement of the balloon-tipped, flow-guided catheter by Swan-Ganz have been pivotal, enabling bedside monitoring and cardiac output measurement. Right heart catheterization is considered the gold standard for diagnosing pulmonary hypertension and PAH. It allows clinicians to assess hemodynamic severity and vasoreactivity, helping to classify patients into one of the 5 recognized clinical groups of PH. This table outlines key recommendations for the use of RHC. It underscores the importance of confirming PAH diagnoses in expert centers and using the procedure to support critical treatment decisions across various clinical groups. The hemodynamic classification of pulmonary hypertension relies on specific parameters. As shown in this table, definitions for PH, precapillary and postcapillary types are distinguished by mean pulmonary arterial pressure, wedge pressure, and pulmonary vascular resistance. At the 6th World Symposium on Pulmonary Hypertension in 2018, the definition of pulmonary hypertension was redefined. The upper limit of normal mean pulmonary arterial pressure was adjusted to 20 millimeters of mercury, reflecting its association with increased mortality. The 2015 ESC-ERS diagnostic algorithm highlights the systematic approach to PAH. It begins with assessing echocardiographic probability, followed by investigations for left heart or lung disease, and concludes with RHC to confirm the diagnosis. The updated 2018 WSPH algorithm streamlines the process by emphasizing fast-track referrals for high-risk patients. It prioritizes screening for CpcPH and ensuring that patients without significant comorbid disease are promptly referred to expert centers. This table categorizes the echocardiographic probability of pulmonary hypertension. Probability levels are determined by peak tricuspid regurgitant velocity, combined with the presence of other echo signs, such as those from the ventricles or pulmonary artery. Risk stratification is essential for managing PAH patients. This table presents key parameters such as WHO functional class, 6-minute walk distance, and NT-proBNP levels, which help classify patients into low, intermediate, or high-risk groups. Following the 2018 WSPH guidelines, a simplified risk stratification method is used. Patients are assigned to low, intermediate, or high-risk categories based on the number and severity of their clinical and hemodynamic variables. Regarding technique, right heart catheterization is performed on stable, resting patients. The right internal jugular vein is typically the preferred access site, and the procedure is efficient, often taking only 15 to 20 minutes to complete. The choice of access site depends on the specific clinical requirements. While the jugular is preferred for most RHC procedures, the antecubital vein may be used for exercise studies, and femoral access is common if left heart catheterization is also required. Finally, the insertion process involves advancing the Swan-Ganz catheter through the right atrium, into the right ventricle, and ultimately into the pulmonary artery. Pressures are meticulously recorded at each location to provide accurate hemodynamic data. Accurate pressure measurement begins with transducer zeroing. The reference point is the mid-thoracic line. Failing to standardize this can lead to significant measurement differences of up to 8 millimeters of mercury. The system records pressures in the RA, RV, and PA alongside cardiac output. This table lists essential hemodynamic parameters derived from your measurements. Key calculations include the transpulmonary gradient and pulmonary vascular resistance. Notably, cardiac index is a critical prognostic factor, corrected for body surface area using the Dubois formula. Here we compare expected hemodynamic values between a normal subject and a patient with pulmonary arterial hypertension. You can see clear differences across key parameters like RV systolic pressure, mean PA pressure, and pulmonary vascular resistance. Age significantly influences pulmonary hemodynamics. As shown here, normal pulmonary vascular resistance tends to double over the first 5 decades of life. A high PVR in the presence of a 5-liter per minute cardiac output often indicates substantial pulmonary vascular loss. The right atrial pressure trace displays 3 characteristic positive deflections, the A, C, and V waves. These correspond to atrial systole, the tricuspid valve bulge, and passive venous filling. Additionally, the X and Y descents provide critical insights into atrial relaxation and emptying. Pathological changes in the right atrial waveform help diagnose specific conditions. For example, elevated waves may suggest tricuspid stenosis or reduced RV compliance, while absent waves are a hallmark of atrial fibrillation or flutter. The pulmonary artery wedge pressure trace mirrors the right atrial waveform but is higher, damped, and delayed. Because of LA constraint, the versus wave typically exceeds the A wave. Remember, the signal is phase delayed, requiring careful timing relative to the ECG. Technical limitations can affect PAWP readings. A significant number of tracings are either inadequate or misinterpreted. It is vital to validate the wedge position by aspirating blood from the distal port, which should confirm arterial oxygen saturation. When reading the PAWP, the respiratory cycle matters. While end expiration is the standard measurement point, special cases like COPD or obesity might require averaging over multiple respiratory cycles to account for pressure swings and prevent misclassification. Timing relative to the cardiac cycle is also crucial. In sinus rhythm, we average the A wave. In atrial fibrillation, we measure 130 to 160 milliseconds after the QRS onset. Be cautious. ACE incorporating the versus wave can lead to overestimating PAWP. Current consensus from the World Symposium on Pulmonary Hypertension remains consistent. The cutoff for precapillary pH is 15 millimeters of mercury. It is essential to use end diastolic measurements, as previous methods using respiratory means contributed to a historical diagnostic misclassification. In the pulmonary artery, systolic notch patterns indicate normal valve closure. Pathological traces, such as Abifid waveform or specific pressure relationships between the diastole and wedge pressure, provide diagnostic clues for mitral disease, pulmonary hypertension, or RV ischemia. When pH is due to left heart disease, clinical phenotypes are key. Look for patients over 60 with comorbidities like hypertension, diabetes, or obesity. Echocardiographic findings, such as LA enlargement and specific mitral inflow patterns, provide further supporting evidence. This probability table helps distinguish between PAH and pH associated with left heart disease. By assessing factors like age, comorbidities, and atrial fibrillation status, clinicians can better stratify the likelihood of an underlying left-sided heart condition. These flowcharts guide the hemodynamic assessment process. They assist in determining which patients require RHC based on their risk profile and help interpret results to confirm or exclude phosphorus monohydride HFpEF, including the potential use of provocative testing. Right heart catheterization carries some inherent risks. Access-related risks include hematoma and pneumothorax, which are significantly mitigated by the use of ultrasound guidance. Catheter-related risks, while rare, include arrhythmias, infection, or perforation. Serious adverse events are infrequent, occurring in roughly 1% of cases. It is important to be aware of contraindications. Absolute contraindications include the presence of right heart masses or mechanical valves in the tricuspid or pulmonary positions. Relative contraindications involve factors like coagulopathy, pacemakers, or active infection at the site, which require careful clinical assessment and risk-benefit analysis before proceeding. This video examines the limitations of right heart catheterization, or RHC. Measurements are typically obtained under resting, supine conditions, which may not accurately reflect hemodynamics during activity, sleep, or when upright. Studies show that pulmonary artery pressure can exhibit significant spontaneous variability. Acute vasodilator testing is an advanced RHC procedure used to identify patients who may benefit from calcium channel blocker therapy. It is specifically recommended for patients with idiopathic, heritable, or drug and toxin-induced pulmonary arterial hypertension. This table outlines various agents used for vasoreactivity testing. Inhaled nitric oxide is the recommended agent. Other substances, such as oxygen or PDE5 inhibitors, are not currently recommended for this specific procedure. Registry data provides insights into long-term vasoreactivity. While 12.6% of patients were acute responders, only 6.8% remained long-term responders without specific PAH therapy. These patients are now classified under a specific subgroup. Exercise testing during RHC helps assess how the pulmonary circulation responds to increased cardiac output. In healthy subjects, stroke volume increases with exercise, leading to only minimal rises in pulmonary artery pressure. The protocol for exercise testing involves a stepwise increase in workload on a supine cycle ergometer. Hemodynamic parameters are recorded during the final minute of each exercise level once the patient reaches a steady state. Defining an upper limit for exercise-induced pulmonary hypertension is challenging. Factors such as the lack of standardization, high false positive rates in healthy individuals, and the physiology of elite athletes have complicated the establishment of universal criteria. This table illustrates how the upper limit of normal mean pulmonary artery pressure varies by age and exercise intensity. These clear age-dependent differences highlight why a universal threshold remains difficult to define. While proposed criteria for exercise-induced pulmonary hypertension exist, they are not currently part of the formal clinical definition. More data is required to understand the natural history and clinical relevance of these measurements before they are used to guide treatment. Research by Conliffe et al. Provides evidence regarding high-risk patients. Their findings suggest that an elevated mean pulmonary artery pressure during exercise, despite normal resting levels, may serve as an early indicator of developing pulmonary vasculopathy. A fluid challenge can be a useful diagnostic tool during RHC. It helps avoid the incorrect diagnosis of PAH in patients with heart failure who have been heavily diuresed by unmasking elevated filling pressures that might otherwise be hidden. Studies, such as those by Fujimoto, show that healthy subjects maintain relatively stable pulmonary artery wedge pressures during fluid administration. In contrast, patients with heart failure with preserved ejection fraction often demonstrate a steeper rise in pressure. Practical recommendations for fluid challenge include a standard protocol of 500 milliliters of saline. Guidelines suggest considering this test when the probability of pulmonary hypertension related to left heart disease is intermediate to high. When comparing exercise challenges to fluid challenges, both offer unique benefits. While exercise testing assesses symptoms directly, fluid challenges are easier to perform, require no special equipment, and use well-established pressure cutoffs. Finally, we consider the diastolic pulmonary gradient. Proposed in 2013, this measure is designed to better assess pulmonary vascular disease, particularly when distinguishing between pulmonary arterial hypertension and pulmonary venous hypertension caused by left heart disease. Burgess and colleagues demonstrated that a diastolic pulmonary gradient greater than 7 millimeters of mercury is a predictor of poor survival in post-capillary pulmonary hypertension. Their ROC analysis highlights the gradient's superior ability to discriminate between pre- and post-capillary conditions compared to mean pressure metrics. The survival data regarding the diastolic pulmonary gradient is nuanced. While some studies show prognostic value in Group 2 pulmonary hypertension, others, such as work by Tampakakis et al., found that this gradient did not consistently predict survival in patients with specific left-sided heart disease profiles. Measuring the diastolic pulmonary gradient presents several challenges. The margin for error is small, so variations in measurement technique are significant. Furthermore, phase delay in QRS-gated pulmonary artery wedge pressure can lead to overestimation of the true gradient. The definition of combined pre- and post-capillary pulmonary hypertension has evolved. Initially, the diastolic gradient was the primary focus, but due to prognostic uncertainties, recent guidelines have integrated pulmonary vascular resistance into the definition alongside transpulmonary and diastolic gradients. Clinically, combined post- and pre-capillary pulmonary hypertension is a significant concern in Group 2 patients, often indicating an increased mortality risk. However, the field continues to debate the best way to identify vascular disease in patients with left heart dysfunction. Understanding pulmonary vascular resistance involves certain assumptions. The standard formula assumes a linear pressure-flow relationship, which may not always hold true. In practice, resistance can decrease significantly as cardiac output increases, particularly in young, healthy adults. In patients with pulmonary arterial hypertension, stroke volume is often reduced and remains fixed during exercise. This means any increase in cardiac output relies on the heart rate response, which explains why these patients may not tolerate beta blocker therapy well. Exercise-induced pulmonary hypertensive responses are not always pathological. While elite athletes may show high pressures due to extreme flow, others may exhibit late-stage pulmonary vasoconstriction. Exercise testing can help correlate these hemodynamic findings with patient symptoms. Echocardiography remains a vital screening tool for pulmonary hypertension. Signs are categorized into ventricular, pulmonary artery, and atrial assessments. To reliably increase the echocardiographic probability of the condition, signs from at least 2 different categories should be present. When performing internal jugular vein cannulation, patient positioning is key. While anatomical landmarks guide the process, ultrasound guidance is strongly recommended to simplify localization and improve safety during the procedure. During catheter passage, tips like deep inspiration or elevating the shoulder can assist in difficult cases. Once in position, aspiring bright red blood from the distal tip is crucial to confirm a true wedge position for accurate readings. Oxygen saturation levels provide critical information during RHC. Mixed venous saturation is useful for risk stratification, while comparing saturation levels across different heart chambers allows for the identification of potential shunts. While RHC saw a period of underuse, it remains the gold standard for diagnosing pulmonary hypertension. It is essential for modern classification, and when combined with precise measurement techniques and provocative testing, it provides indispensable data for managing complex patient cases.